Our final formal presentation for this session comes from Professor Ben Moll. He's requested a short introduction, so I'll say the two most important things. He's the convener of today's conference. He's a professor of obstetrics and gynecology at the University of Adelaide. He also asked that I convey his professional adage, which is, a day without randomisation is a day without progress. Ben Moll.
Yeah, thank you, Tanya, and thanks for the opportunity to being up here and share some things that I'm excited about. See if we can click through. Use the mouse. Good tip. This is my conflict of interest. And another thing you should know is I'm a 1965 Dutch home delivery, born over 42 weeks. So by current obstetrics standards, I should be lucky to be alive. And I'll come back at the end of the talk. So what I want to do with you is, from an international perspective, until 3 years ago I worked in the Netherlands, share some thoughts with you about where initiatives are going and then identify opportunities from that. And first is, I'm an obstetrician. Our biggest problem is preterm birth, and we have a variety of interventions potentially to prevent preterm birth, but we don't know which is the best intervention. And that is driving research. 10 years ago, progesterone was a new big hit, so studies were published, and while I was doing studies in the Netherlands, there was actually a publication in the New England Journal showing that progesterone was not effective in the prevention of preterm birth in women with a twin pregnancy. And then 2 years later, Jane Norman published a study in The Lancet with exactly the same results, and then the other 15 studies came along, all publishing exactly the same. So the question we had is, at that moment, couldn't we have done better? I mean, we took action and we did an individual patient data meta-analysis published recently where all the original authors contributed. And importantly to say that although the overall findings of each individual studies were negative, there was actually a subgroup of women with a short cervix and a twin pregnancy that seemed to be benefit from the use of progesterone. But we learned from that, and in studies following the progesterone studies, we evaluated the pessary. It's a very simple intervention on the right bottom, developed actually in 1959 and costing $40. But at present, we have indications that it's potentially effective. This is a subgroup analysis from a study I did in the Netherlands, where you can see that on the left side, women with a pessary, 90% of the children survive without disability, and without the pessary, that is only 70%. And the big difference here is mortality due to delivery at 23, 24, and 25 weeks. So having seen that result, actually the researchers around the world involved already in the progesterone studies then said, we are going to do pessary studies. But the big difference is that we have found each other and that we actually work together, not in one study, but we have shared our research protocols with each other. We have similar definitions of endpoints, and we plan to do an individual patient data meta-analysis at the end of the study. Lisa Esky, who is in the audience, is the methodological coordinator of that work. So I think that is great progress. Here are the studies done in women with a singleton pregnancy and studies done in women with a twin pregnancy. And another great thing to share with you is that it's actually picked up with a funder. So earlier this year, there was a big publication in The Lancet on women with a singleton pregnancy and progesterone, again done by Jane Norman. I showed another study from her that showed that progesterone was not effective if you looked at the development of children at the age of 2. And that completely confused the field, because there were actually many societies and countries that were using progesterone. So one of the American stakeholders, March of Dimes, went to PCORI, which is the Patient-Centered Outcomes Research Institute in the US, and actually said, we have a problem here. Could you help us? And PCORI is going to fund an individual patient data meta-analysis of all the progesterone studies done thus far and ongoing. They will fund it with $400,000. And importantly also, they will use rigorous methods. So they have developed a structure where trialists will supply data. There is a secretariat where patients will be very important in defining outcomes and interpretation of the results. And in the middle will be a technical team that is completely independent of the people who are involved in the earlier studies. So I originally applied for doing that job, but I was excluded because I was a researcher in a smaller study at an earlier stage. And I think this is a very important development because it allows us to collect the data in the best form of meta-analysis. And I think we should all be aware of that. So I will take you now to two health systems. First, slides from a colleague from the United Kingdom, Andy Shannon, who is involved, just as I am, in clinical trials. But I have some slides from him actually to share with you, I think, an exciting development in the UK where there is a strong professionalization of the incorporation of research into clinical practice. So there is there an Health and Societal Care Act that places a clear of duty on the Secretary of State, the NHS Commissioning Board and clinical commissioning groups to promote research on matters relevant to the health service and the use in the health service of evidence obtained from research. And very importantly, actually, it says patients have a right to participate in a clinical trial if they are suitable for it. So it puts some pressure on the healthcare provider in the system, actually, to allow patients to participate in trials. And that then is hopefully leading to rapid adoption of effective innovations to characterize or to implement in the service. So the strategic aim of the NIHR is to improve the health and wealth of the nation, UK, through research. And what has happened there is that there is a budget from £1 billion, actually obtained from the universities, put back into the health system to facilitate specifically effectiveness research and trials. So the goals are to transform research in the NHS, increase the volume of applied health research for the benefit of patients and the public, develop and support the people who conduct and contribute to applied health research, and also to support industry and growth. So importantly also, there is a quality requirement there. So only research is supported that is demonstrable of high quality. That can be done, or it should be done into a clinical reach network portfolio. So if your study is not in the portfolio, you will not be supported by the network. And you can come in that portfolio either by being funded in an open national competition with peer review in the UK, or to be considered by an adoption panel. But once you are in that network, then actually as a trialist you get support. So sessions of clinicians to support your study will be financially supported. You get research nurses and other research support staff that actually collect the data for you. You get support in research management. There is support of routine services, but also I think very important for us, imaging and pharmacy, knowing needed to run trials is supported. And most importantly also, so Andy Shannon, who sent me these slides, actually organizes this so efficient in his own region that he makes money from it. So he gets more money for the recruitment of patients than the cost he is for individual research nurses that he pays. And that potentially drives the system to very good recruitment rates. So there are all kinds of specialty groups, each of them organized within the UK in regions. And it has led to an enormous increase in recruited patients because people at various levels have an interest in recruiting patients. The number of recruited patients into studies has come up from just over 200,000, not even a decade ago, to more than 600,000 in the last year that I could find the data of it, 2014, 2015. And I think this is a very important example and lesson for all of us to see how we can improve. Now I take you to my previous home country, the Netherlands, where there is a project going on that's called Leading the Change, and I'm proud to say that's also partly inspired by the studies that were done by obstetricians, gynecologists in the Netherlands. So Steve Webb already showed this slide this morning, but at another he had a bar chart, actually demonstrating that from all the healthcare that we provide, about 50% has an unknown effectiveness, and still we, or society, pays money for that. So that is a slide that we showed over and over again in the Netherlands to specifically the insurance companies, and actually said to them, realize that you're funding things that we don't know whether they are effective. And then we created a system where what we knew was summarized in guidelines. The idea was then to implement guidelines, validate them, and evaluate in a continuous circle, with the idea that new things only enter the system once they are evaluated. And that, I think, is accepted by many stakeholders. So the change is to recognize that we do not know everything, transparency, determine what we do not know, so identify knowledge gaps, evaluate what we do not know in healthcare evaluation and trials, formulate knowledge of care evaluation in guidelines, and then subsequently implement and monitor. And all the stakeholders in the Netherlands have actually adopted these 6 points. So what has happened is that the groups on the right side of the slide, so these are doctors, but also hospitals, importantly insurance companies, patient organizations, have said we're going to support this process. So we're going to identify knowledge gaps with the professional societies. We're going to evaluate effectiveness, and then we're going to actually support the development of guidelines and measure that. And importantly, that whole process is funded and supported by the insurance companies. So this is independent of the Dutch NH and MRC, SON and W, but the insurance companies have said we are going to reserve 15 million euros in 5 years to support this process in 20 new evaluation process, but importantly also 40 monitoring process. And for example, the Tranexamid studies could be very well an implementation process in the Netherlands, because that actually does not only happen or save money in Australia, but also in the Netherlands. So importantly, there will be a central clinical trial center for all the trials that are run, and the professional organizations, so the colleges, will be co-applicants among those projects, which makes actually the doctors also responsible for recruitment and execution of those processes. So these were the 3 examples I wanted to share with you. If you think about this and actually think in your own field or own situation, how you can reach out to people internationally, I think that what I want to achieve with this talk, and I would be very happy to share experiences. I was inspired by Ian Seppelt, who last year won the prize of the best project grant from NH and MRC, and when he got the prize from the minister, Susan Ley, he said, well, I have a problem, because actually our study goes through 4 countries, New Zealand, Australia, the UK and Canada. And we won the prize in Australia, we were funded in New Zealand, but in the UK and in Canada we didn't qualify, so I can't start this excellent project. Which I think symbolizes that we reach out to other countries, but if we are not supported by the other stakeholders, then that will be difficult. So I would say continue individual exercises, share it, but also inform stakeholders, insurance companies, etc., about the importance of international coordination. So I come back to my year of birth. That was 1965. My parents, you can see here, married in 1956. I am the oldest son, and I don't have any sisters. So actually my mother suffered 9 years of infertility in an area that there was no IVF. And as far as I'm aware, she had an hysterosalpingogram in November 1964 that actually allowed then the way to my conception. Now you will say, why does he share that with us? I'm excited to say that I've been involved in a randomized trial that actually evaluated 2 types of flushing at an hysterosalpingogram. It's favorably received by a big American journal, and it shows that oil blue is much better than green tubal flushing with water. And the reason I show it is that it took us 50 years actually to solve that issue in our field. And I think we should all learn from that, because I think there is much, much room for improvement. As a matter of fact, at time 0 in the Australian fertility clinics, everybody starts in vitro fertilization already. So there is a huge room for improvement, I would say, to do trials and also show the impact of that. And if I'm at this slide, I always stop talking. A day without randomization is a day without progress. Thank you.